Welcome everybody to the Random Anesthesia Topic podcast. In this episode, we have Dr. Natasha Bartel from King's Animal Hospital in Ontario, Dr. Ryan Bailey from Premier Veterinary Group in Chicago, and I'm Dr. Gianluca Bini, owner and founder of Safe Pet Anesthesia, a training and teleconsulting company, and I'm an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. Tonight with us, we have Dr. Pockel, which is a board-certified behaviorist and is the owner and lead clinician at the Animal Behavior Clinic in Portland, Oregon. He lectures worldwide. He teaches a bunch of courses. I met him at DVM 360. So welcome, Dr. Pockel. And I want to break the ice with our first question. And my question is, do you accept consults for chill protocols for surgeons? Can we
Are you talking about the surgeon or the patient? Which one are we chill protocoling here?
The surgeon.
That's a great point, and you could do me a favor and apply it to the surgeons, please.
Yeah. Can we come up with a protocol so that we just chill them out before they
right.
come to work?
So I full disclosure, my husband is a veterinary surgeon, so I hear everything you're saying. I will say he's kind of an exception. He's kind of a unicorn in the surgery world, but also I have to mind my P's and Q's slightly because he and I have been together 25 years. And so
you don't, Chris, because surgeons aren't going to listen to this podcast because they already know everything.
Also true.
Yeah, you can say
not wrong. Not wrong.
Yeah, you just like have at it. But yeah, surgeons aren't going to listen to our podcast. So, that's why we're able to lay into them. So.
That's fair. That is fair.
No, they definitely don't listen to this. So you can say whatever, feel free, you're good. But on a serious note, so, there is a lot of overlap from, drugs that you guys use and, we use, right? So we, for example, Acepromazine is one of those, right? It's for us, it's more like considered like a sedative, quote unquote, right? Versus in behavior, you guys use it more like sort of like a chilling, like tranquilizing.
So now here's the question. Before I tell you what I think about it, how would you differentiate sedation from tranquilizing?
Ooh.
Yeah, Gianluca, this is an exam question in anesthesia.
There you go. And Ryan, what do you think?
Down for 0 on this one. This is like the attack the other day is taking the VTNE, and she's like, "What's the difference between emergence delirium and dysphoria?" And I was like, I don't know.
Well, there is in fact a difference because usually dysphoric patients, you can't actually comfort them, whereas emergence delirium, they tend to self-resolve with time, not due to a dysphoric overdose of one of the anesthetic agents. And you can actually comfort them and their eyes will track. So
there you go. All right. So there you go, Bartel. Why don't you tell us about tranquilization and sedation? And
the difference is one of them, you can actually rouse the patient out of it, and the other one you theoretically can't.
Which is which? Just so I know, because not in your world.
Right. Well, see, this is where I start to have a semantical and philosophical argument with myself, because I would assume that in terms of tranquilization, that would be the one where you can actually like calm them down and then they're rousable, and then sedation is the other way around. But actually, the last time I checked the textbook, it's the other way around. So
yeah, my brain put them in the other direction.
Exactly.
So, yeah.
Oh yeah, because like for me, like tranquilization means you have become, just going back to the, the Latin root of the word, that you are tranquil, but still rousable, but it's the inverse. So
yeah.
That's okay.
Right?
Is that the
learning
first
all the things?
Good to know. Thanks.
That's the exam, Bartel. You can.
I know, and I did it on the first time.
I think we're done for tonight. Thank you so much for being here. Bye.
Maybe we should split the podcast to the senior anesthesiologist and the junior anesthesiologist.
There's 1 year of separation between all of us?
I actually have no idea.
Yeah.
That's awesome. So when do
Was there a
you?
question in there somewhere for me? I've completely lost the thread.
I thought we were still on the chill protocol.
Still on Acepromazine, I thought.
I mean, the question was like, so how do you? So when would you prescribe acepromazine, right? Like, is what's the situation where that triggers you to prescribe that over some other drugs, or maybe some just some different training, I guess.
Yeah.
So what's your thought process when you guys prescribe that?
So the way I think about that from the behavior lens, right, is so acepromazine falls into the category of situational meds. So we typically differentiate maintenance meds like your Prozac antidepressant, everyday, long-term, 4 to 6 weeks for efficacy, versus your situational meds. You give it, it takes effect in half hour, 2 hours, whatever drug we're talking about, right? And then there's no residual effect. So acepromazine, for obvious reasons, falls into the situational med category. So then the question is, in terms of actual desired effect, are we actually likely to see any anxiolytic effects or any actual emotional arousal regulation sort of a benefit from it? Or are we talking more about sedation or more about blocking or limiting motor activity? And I will say in the behavior world, ACE has gone through kind of a variety of lifetimes, even in my career over 20 years or so, where back in the day, when I think back to even my pre-vet days when I was working as an assistant in a clinic, ACE was one of the only things that was given situationally. It managed the clinical signs of whatever was there from a behavior perspective. Clients often loved it because the animal who was destructive during thunderstorms, for example, just laid in the corner and slept and drooled all over everything. And so clients loved it, right? And yet there was a limiting factor in that there's very limited anxiolytic effects. And so if anything, we may be sort of blocking some of the expression of anxiety or emotional distress, but not actually providing clinical benefit from a behavior perspective. So for me, all of that to say, when I'm prescribing ACE, it's typically when I'm looking specifically for that control of motor activity. So in my world, if I have an animal who has big feelings about life and I'm trying to manage that, ACE is typically, the third or the fourth layer to that protocol when the anxiolytic effect that I've gotten from other drugs is insufficient to manage the motor patterns of the patient. And I'm often using it temporarily, even to control that pattern until we're able to get other training or behavior modification onboarded to actually address the underlying issue. So I will say personally, I prescribe ACE twice a year, maybe.
Oh, wow. Okay.
It's really, really uncommon. Now, keep in mind, I'm on the behavior specialty side of things, as opposed to in the general practice where I'm needing to do injections and other protocols and procedures where the chill protocol becomes much, much more relevant. So I'm advising on that when we have clinicians who need to be able to address that. And I will say, as I was saying with the ACE lifetimes issue, we went from that sort of ACEs everything to ACEs the devil because it doesn't do anything that we thought it did. And then everybody was like, no, never, 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 never. And then with the emergence and the popularity of the chill protocol, I'm seeing it showing up more frequently now in some of my referral records coming in, where it's being prescribed a bit more freely, again, as a way of managing or controlling longer term behavioral patterns. I have mixed feelings about that, whether I think that's actually the right way to go, but it's something that we're likely to start seeing a bit more frequently.
I have two questions. Chris, just for the listeners, can you just give us a quick overview of the chill protocol and its indications and how it's actually clinically managed, just so the listeners can catch up? That would be really helpful.
Absolutely.
Thank you.
Yeah, so Chill Protocol was originally kind of put out into the world from the team at Tufts. At least that's my understanding of where it originated, right? So looking at typically a pre-visit pharmaceutical protocol, something that would be given most often to a dog, potentially for other species, but most often to canines, as a way of alleviating some of that emotional distress or creating a bit more of a managed patient for the veterinary experience, either in advance of other sedation or as a standalone, kind of helping the animal feel better about the experience. From a drug standpoint, standard chill protocol typically includes acepromazine, the one we're talking about here, gabapentin, and melatonin. Modified chill protocols, depending on who you ask, may also include trazodone within there as well, but the original version did not include that in the protocol. So we're looking at that, again, typically something that would be administered 1 to 2 hours prior to veterinary appointments, plus or minus 12 hours before that, as a way to kind of facilitate that sedation and overall behavioral regulation and calming. And then presumably, if it works, then we're able to more easily manage that patient within the clinical setting.
Let's just highlight that presumably if it works, because that was highly conditional. And my next question was going to be, how often are you using the chill protocol? But I feel like you kind of just gave up the ghost there. So
Yeah, it's, I think the thing for me that is sort of an interesting thing about that, and this is actually where I love the intersection between behavior and anesthesia, is if I want an animal to quote unquote feel better, managing that patient with gabapentin, melatonin, and acepromazine is going to be really intermittently effective,
I mean,
depending on how you feel about gabapentin, right?
Tip top.
If we get more trazodone on board, maybe it's going to be more effective. But truly, from an anxiolytic effect, I'm a much bigger fan of clonidine or benzodiazepines or some of the drugs where we're actually getting that anxiolytic effect. With that being said, I have a lot of practitioners who swear by it, who love it. I don't know that I generally see that level of effect that would make me say this is going to be my default. I'm not opposed to using it if it works for a particular patient, but yeah.
Yeah. I mean, in some practices nowadays, that's the standard, right? Like
Yes.
there is no option, right? Like every single dog or it comes in with the chill protocol in, right? And there is no option. Like even patients that totally do not need it, they just randomly blanket prescribe it to everybody, right? It's like candies.
Oh, that has not happened yet in Canada, but that could be
Yeah, I
because of
don't
the tariffs.
I don't see one question I had, and I like, do you think, just everyone, there's a big, so like I personally feel very strongly it is a the night before and day of, if you're really gonna do it, it's gotta be the night before and the day of, because like there's something, I don't know if it's our body language, our behaviors at home, something changes before the day before the vet visit. And I find a lot of times those patients who are coming in on these like calming, tranquilizing, sedating meds are not, they're like, there's no effect if they're just the day of. And I suspect it's like pulling food at nighttime, changes in some sort of behavior pattern that we aren't perceptive to, but I think our patients are. So I wondered if you guys have any thoughts on that.
So whether to do it both night before and day off, or just
I'm pretty much, I'm like 100% across the board. It should always be the night before and the day of the procedure.
Yeah. I
yeah,
think what you're highlighting within that, at least from the behavioral world, is if we're going to use situational meds for whatever it is, thunderstorms, separation anxiety, veterinary visits, we really need to make sure that those meds are on board, give or take 2 hours before the onset of the stressor. It's not 2 hours before the veterinary appointment. And what often gets missed is, as you're saying, if there are changes to routine, especially if we're talking about anesthetic protocols where we're changing the mealtime routine, if I have clients who are not sleeping well the night before, and that, all of those things that get sort of wrapped up into it, then I totally agree. 2 hours before the onset of stress would almost dictate that we're talking about night of. I would say the same thing is also true if I have a patient who has more of a generalized or longer term anxiety issue, that even if the owner is not changing their routine, I think if we're leaning on a situational med, especially if that generalized anxiety is not terribly well controlled, we're asking a lot of that situational med to cut through all of that and alleviate the distress of the actual experience, versus can we, pardon the pun, chill them out the night before and then kind of top them off the morning of and kind of just ride that wave, as opposed to trying to get through all of it morning of.
yeah,
Nice.
no,
I
that
like
totally
that
makes
idea.
sense.
Yeah. Yeah, because my cat, you can't even go into the closet where the cat carrier is before we all get collectively upregulated. So now, Chris, I have something. First of all, I'd like to thank you for being a guest star this evening. Before I say something controversial about behaviorists, which is, I just wanted to, hear your thoughts. For a long time, like you said, acepromazine fell out of disfavor. And I still think it has, right? Like I still have ER doctors who are like super reticent to use it clinically for sedation. And there was this, I don't know which ethos going around that acepromazine was actually not mindful of the patient's welfare because it was not an appropriate anxiolytic, which meant that what was happening is it was sedating the patients, but leaving them in a terrified mental and emotional state, which I personally think is a gross overstatement and, hogwash, because there is dopamine receptor activity, but more importantly, just chilling them out just in a sedative capacity, theoretically, and feel free to comment on this, can secondarily just alleviate anxiolysis outside of a pharmacological pathway, right? Like if you gave me an alprazolam right now, well, that's a bad example because alprazolam is different. But if you did give me, shut up, edit that out. But yeah, like if you gave me the acepromazine right now and like took me down about 5 notches, I think inherently my anxiety drops secondarily to the fact that I'm literally just in a sleepy state.
So, and I think that the differentiation there, and again, this is back to like a sedation versus tranquilization, is are we talking about anxiety versus arousal?
Where's she going?
And
Happening here?
someone's at the door.
Sorry, I get my groceries delivered, which is ironic because I eat Rice Krispies for dinner. So I didn't have time to go grocery shopping because I took a 3-hour nap, guys. Okay, like it's one or the other.
For me to judge. So back to what you were saying there. I think the one of the differentiating factors for me on the behavior side is, are we actually getting anxiolytic effects? Anxiety being that apprehensive anticipation of threat, which is inherently an emotional response, as opposed to activation or arousal, kind of that degree of physiologic activation. And the difference is that for some of my patients, sort of deactivating does have a calming effect on an emotional state, that it sort of prevents some of that wind up. And so then I agree that I wouldn't say sort of as a blanket statement that sort of chemical straitjacket effect is going to be there for those patients. Where I think it gets a little tricky is that for those who truly do have anxiety, where there is an apprehensive anticipation of threat and there's a level of worry, especially if those dogs are generally more active responders, where anxiety manifests as pacing, panting, whining sort of movement, taking away the ability to do that if we're not getting the anxiolytic effect, I think is the patient that I have concerns about. To then say in that scenario, which again, patient selection criteria for everything is key. For that patient, do we take away the expression of that emotional distress, essentially masking it, and then and then potentially still the animal is still experiencing that? So from a sensitizing effect or experiential learning, we're actually still perpetuating that underlying emotional state. And that is something I've had patients over the years, especially back in the day when ACE was more commonly prescribed, where the owners would say, as long as I give ACE ahead of time, we're great. They run out, animal experiences the storm or the separation without that support on board. And I've, case examples where those dogs were significantly worse than their pre-medication baseline. And one of the possible explanations is they've continued to sensitize, but we didn't have visibility of that. And then when the masking support was taken away, do we actually have patients who are actually worse off as a result of it? Not that that's necessarily the case for every dog, but I think it's a relevant consideration when we're figuring out what are we actually trying to achieve.
Yeah, that's fair. Actually, I didn't think about that. That's. Huh.
Yeah, excellent. Thank you. That was a lot more eloquent than the question I posed, but
I mean, again, remember, I'm a behaviorist.
By the grocery delivery, so it was knocking, and I was like, "Just put it on the porch." But he was very concerned about the ice situation, so fair enough, grocery delivery guy. I appreciate it, but
Fair enough.
yeah. I just, so many times, you would see on like listservs and Facebook feeds going back and forth that like ACEs was allowing the patient to be tortured while it was just being physically sedated. And like I said, I feel like that's a bit of an overstep. And really what it ended up happening as a consequence was that it really like threw acepromazine out of the toolkit, and in a way that I think has been detrimental to the patient population, because acepromazine, particularly in cats, can be a really helpful clinical sedative. So
yeah, and I think for me, I think coming that maybe not full circle all the way back around, but kind of what was old is new again sort of an idea. I think there's a balance point in there somewhere, where if I think back to when it was sort of the only drug and it was prescribed without any nod to selection criteria or patient need, I think that's problematic. I think completely getting rid of it and not recognizing the value it can have, especially in a multimodal protocol, I think that's also doing patients a disservice. The question is sort of, how are we identifying who within the middle would actually benefit? Do we have awareness of what those factors are to then identify, was it helpful in the way that we thought it was or not? And then to be able to use it on an ongoing basis in the patients for those who it actually is helpful for.
Yeah, the surgeons. So I think we can all agree on that.
I do want to just add a little note to this ACE discussion, given that one of my coworkers has a big passion for the ACE anxiety issue, and she dug into some older papers showing, like, these are all human-based, human-centric papers. So a lot of them were in very elderly people, I believe, and they showed, improved anxiety scores in some of the older generations of the phenothiazine, like, tranquilizer family. And again, humans are not dogs. Dogs are not humans. I think there's a total difference in, what we are using the drugs for versus, what you're going to be using the drugs for, Chris. Like you said, like,
You're going to say what you were using old people for.
no, no. I mean, there's a total difference in dealing with someone who had, like, as someone who has a fair level of anxiety in my own personal life. There's a difference in the kinds of drugs I would want to take to manage that level of anxiety I experience and be a functional human who can still do anesthesia versus, like, a dog who's waking up and is either experiencing emergence delirium or dysphoria and needs, something to take the edge off for, a few hours.
Well, and I think, especially when we make some of the canines or feline comparisons to humans, one of the big differences there too, especially from a cognition standpoint, is the level of awareness of what's happening around you.
Yeah.
And to what degree do we have a human who's opting in for care and sort of feels better when some of that arousal has been reduced, but they're still sort of consenting, there's still a participation factor, versus an animal for whom something is being done to them.
Yeah.
Depending on their coping strategies of how they would ordinarily navigate something like that, I think the chemical effect that we're eliciting can really be profoundly different across those lines.
I mean, you're really giving humans a lot of credit, Chris. I don't know the last time you rocked up to an ER or you watched The Pit. Have you guys been watching The Pit? You have to watch The Pit. It is the best medical show. It is. I mean, they gave BiPAP the other day. They got a tension pneumothorax, and I was just like, yes. So yeah, side note, watch The Pit. But yeah, you're giving humans a lot of credit.
I mean,
That may be true. I don't spend a lot of time in the ER, especially on the human side, thank God.
yeah.
But,
Yeah,
That's
if
a
you
really good
come
point,
down to
though.
anesthesia, you'd be surprised how non-consensual some of the stuff is, or like arm twisting. And then if you're my dad who wakes up from anesthesia, he opens his eyes and shouts, "I'm alive!" So he really has a really exciting emergence.
That's awesome.
Yeah,
That's awesome.
yeah.
So, what do you think about, like, from a behavior standpoint, right? Like, what do you think about this quote unquote abuse of the chill protocol, right? Like, what's your thought on that? Like, do you think it's fair game? Like, the fact that it makes your life easier as a vet sometimes. Do
right.
you think it's fair game, or do you think it's something like, people are a little bit like gabapentin for pain management, right? Like, where people are abusing it like fucking candies, right?
Gabapentin is the new famotidine. You can't get into the hospital without it being administered, right? Like the new famotidine.
It's default on every on.
It's like walk in the door, you get Serenia, you get GABA, you get, like, and it's like, can we all calm down?
So, what do you think, Chris?
I have mixed feelings about it. On one hand, I support more widespread use of anxiolytics from the standpoint that what we often do in the clinic is stressful from the patient experience. And I obviously see some of the maybe not the worst of the worst in all cases, but those animals who don't have the ability, they don't have the resilience to withstand that trauma. And so then I see them when we're really trying to rebuild an emotional coping strategy around what for a lot of animals is actually relatively well compensated for. So again, my lens is a little bit slanted in that direction. So I think being mindful of patient experience and being more liberal with the use of support options, I absolutely agree with. And I actually, as you see with a lot of these patients too, an animal who is either, let's say, immobilized or is experiencing some of the, I don't know what the right word for it technically is, but some of the borderline obtunded effects that we can see from either gabapentin or trazodone, especially for some of my herding breed patients with generalized anxiety, they don't feel better, but they absolutely feel different. And for many of them, that is a really uncomfortable way to be. And so I worry that if we're looking at patients where we're basically just saying everybody across the board gets your chill protocol, gets your trazodone, gets your whatever, number one, I don't know that we even know what our baseline was without that to know if it's making a difference for comparison. Or if we then have a negative patient response or a negative patient experience without that baseline, did we actually precipitate a more difficult clinical experience for that animal by putting something else on board that they're not accustomed to navigating? And then we sort of label that patient as fractious, refractory to treatment, more meds, more meds, more meds. And if we're dealing with practitioners who may or may not fully have that ability to differentiate what is doable with low stress handling or fear-free protocols or reading the animal and truly, sometimes people kind of roll their eyes when I say this, but truly engaging the animal in conversation. I'm not talking about that in a way of saying, what we're going to do today is no, but actually engaging in the body language conversation of, when I move my body in this way, when I restrain you in this way, does that make you better, worse, or no different? And being able to engage that conversation in real time in a way that actually facilitates handling for so many patients in a way that minimizes the necessity of pharmaceutical therapy. But that's not exactly a language that I would argue that most veterinarians speak fluently. And so then we create perhaps an unhealthy level of reliance on pharmacological support as a way of managing that patient. And then it's a slippery slope because you get a couple of really, really nice successes out of that. And it becomes really easy to make that sort of tip into, this is just what we do now. This is where we live. This is how we do it. Here's our protocol. Easy peasy. And we don't have to kind of think about it anymore.
Oh, he says that to 3 anesthesiologists who just recorded a podcast about how we do 98% of our anesthesia the same way.
So
Scully, I was like, oh yeah, this sounds great. Awkward.
There's nothing wrong with that as long as your protocol works for 98% of the patients, or you have the ability to adjust in real time, right? It's an option.
100%, Chris. I have 100% success 100% of the time. Like, hello. Oh God, yeah, no, that was pretty funny. I was like,
oopsie. So Ryan, you were saying, do you use the chill protocol a bunch?
I do not.
Oh, okay.
The chill protocol came around. I don't know when it became popular, but it was not common. So like I'm more, yeah, I definitely fall in the, in the fractious patient who is somewhat less tractable and is coming in for their appointment. I do advocate for some sort of gabapentin or trazodone combination the day before the night before and the day of, just to facilitate our handling and our safety. Is it the best, like long term, definitely not the best option.
I thought you were just darting them out in the reception area.
Yeah, exactly. That's exactly. I just, I do. I get the dexmedetomidine gel, and I just like squirt the whole tube all over their mouth.
I mean, that's not a bad philosophy for some of my patients. So that's all we get sometimes. So
Do you use the Sileo a bunch, like the dexmedetomidine gel?
So I do. I mean, yeah, we use it especially for sort of at-home usage. But no, for a fair number of my patient population, even doing an injectable protocol is it's either insufficient or unsafe
Yeah.
to be able to get that close to some of them. Especially, I tend to pick on the adolescent shepherds a lot, just because it's a population in and of itself. And the biggest difference for some of those dogs, not just the adolescent shepherds, but the difference is, and this is actually a place where, again, the behavior anesthesia interface is actually a real one, is that if you want that animal to feel better emotionally, you want them to feel more settled, more comfortable, more trusting, I can prescribe the heck out of that, either on a maintenance or a situational basis. But if you have an animal that has a learning history that suggests being in the clinic is an unsafe experience, and they've learned that aggressing preemptively is the best way to maintain your own sense of safety and well-being, I don't care how good I make them feel with pre-visit pharmaceuticals, they're still going to do what they do in order to maintain safety. And so the moment I recognize that pattern within one of my within one of my cases, the pattern is then to say, well, you don't need them to feel better, you actually need them to do less, in which case then I'm defaulting over to anesthetic protocols to say, what does it look to just make them sleep so we can handle them safely, not just trying to kind of manage our way through with a feeling better, so to speak.
Damn, that's like so smart. Like nothing I ever think about is like, I mean, I do like, you brought up a lot of good points, Chris. I think one of the best points is like we cannot converse with the dog, and this dog did not opt in to get the TPLO at all. In fact, he's fine with the way he limps around the yard and whatever, and he does not understand his knee needs to be repaired because the owner still wants to run him 3 miles a day or whatever it is. And so like we can make this dog feel good, but he learned a long time ago that he has this maladaptive coping strategy to like attack, and that has worked for him.
I
And
feel
like
like I'm being described. That's exactly how I am in clinics, right? Like if someone rocks up with some dumb anesthesia comment, right? Like I'm going to be like, I'm an adolescent shepherd and you need to get out of my induction space. So yeah, I don't know if I feel supported or attacked or whether I'm in consult with Chris.
At the very least, I think you're seen. We see you in this conversation. We see you, we hear you, we acknowledge your presence in the room.
Yeah, I feel like you described my entire experience as an anesthesiologist, which is you basically have to fight. And so now that's the default. Like you could sedate the crap out of me, and I'm still gonna like come out sparring on the alprazolam. So yeah.
Yeah.
Is it like one for you, one for them? Is it?
Well, Beanie, as you know, I prefer most human beings unconscious.
I think we, as anesthesiologists, we have this weird, like, I think it's actually a behavior issue, right? Like where we have this like aversion to humans. We have, and
That's because we spend most of our time as surgeons. Like, what do you expect to happen? God, like, yeah. Now, no, I mean, one of the reasons a lot of us do get driven towards the specialty is because the client interface is either we've been traumatized or we find it draining, or, like I just really do not enjoy it. So that was definitely a part of my decision process.
That is fascinating because I got into vet med for animals. I got into behavior for people. Like I actually went in the opposite direction, that the opportunity to meet them where they are, to ask questions, to get curious, to understand their pain points, to be able to troubleshoot and figure out exactly what can we do collaboratively? What can I do for you? What do I need you to do?
This is like my worst nightmare. I don't care about anybody else's opinion. Yeah. And like I'm working on my second career right now, which is fostering, like, I want to like buy myself a hermitage and become like a professional hermit. So yeah. No, I could never imagine being like, oh, I want to go do it for the people. Like, who?
So to lighten up the mood, what's your favorite hot dog, Chris? Because Ryan is a hot dog connoisseur. He has like books about hot dogs, and he just what's your how do you eat your hot dogs?
In Reykjavik.
In okay, how did
So
you get
as soon as you started asking the question, I can't tell you exactly what it was, but so we were. I was speaking in Iceland about 2 years ago, And one of the things that is sort of, if you're looking at the Reykjavik, like things to do, there is this hot dog stand that is like one of the things to do. And my husband and I were like, meh, it's a hot dog. Sure, we'll try it. We're here. Check the
Ryan's
box.
face.
Right? I know. Just hold on. Don't judge me quite yet. Like, I'm not a connoisseur, so I'm like, I'm sure it'll be good. Like, I'm sure it will be. I think we visited every single day we were in Reykjavik. I'm like, this is the best fucking hot dog I've ever had in my life. And there was like, again, there was a crunch in there. I don't know if it was potato chips in the bottom or there was something else. And the sauce that was, again, it sounds completely bizarre. The texture, the pop, the bread, everything about it was as close to perfection in a hot dog as you can absolutely imagine. So you might, if you haven't been, it's a hot dog stand sort of just in the kind of the downtown area. Again, you won't have to like Google it. Reykjavik hot dog, boom, you'll find it. And it was the best hot dog I've ever eaten, so much so that I ate many of them.
Well, now we know where Ryan's going on his next
That's
vacation.
a glowing endorsement. Like, to go when you're in a foreign country and there's many things to eat and you're like, this hot dog is the one I'm going to go back to. All right, I'm sold.
There you go, Ryan. You're booking.
It's like it's right up there with like the Greek yogurt and honey on Santorini. Like looking at the caldera, like it is up there next to this hot
That
dog.
is like a wow.
Ryan, maybe you should consider just becoming like a hot dog travel writer where you just like basically travel the world. This could be a great show where you just travel the world visiting like famous sausage and hot dog stands. And, you know, you'll be dead in 5 years from coronary artery disease, but it'll be worth
I'll
it.
be happy.
You'll be dead and happy. Yeah.
I'll feel good.
You can be the new Stanley Tucci.
I mean, that would be my dream. Like, to tour the world just eating all the various hot dogs and sausages would be like, what better life? Like, what a good life.
You know, honestly, I don't disagree. Like, it's clearly better than being an anesthesiologist.
Wah, wah. Which, to the earlier point though, is probably a little bit because of the lack of client interface. Because our clients are our coworkers.
Yeah, and they're honestly, I swear to God, 99.8% of the time, the anesthesiologist's worst enemy is another veterinarian.
Yep.
Yeah, I feel so unsupported by other like clinicians and specialties. It is unreal.
Aww.
So can we talk gabapentin, also known as vitamin D?
If I can shake off the sadness that I feel for your profession, sure.
You have to, like, you just accept that we live under a little black rain cloud, you know.
We don't even, most people don't even know us by name. They just call you anesthesia. Like there is no.
Beanie, at least your name isn't Anatasha. Do you have any idea how much abuse I have to take for being Anatasha, the anesthesiologist? Like,
Well, you're
basically,
kind of destined for
call
that.
me,
That was
like, they call me anesthesia, like, and I'm just like, yeah, no, I get it. It's still not funny, but yeah, like, destiny did not work out in my favor in this capacity. But, yeah.
Is that why you became a chief medical officer now, or?
Yes, so people call me chief instead of anesthesia.
There you go.
wow.
Wow.
That's great, I guess.
So gabapentin.
Gabapentin. That's the bane of our existence.
Well, that's not true, Beanie, because you have this real hate on for lidocaine. So,
Fucking
my
life.
true arch nemesis is isoflurane. Like, brr.
Oh,
Yeah,
It's true, 100%. Isoflurane sends everything to shit. Isn't that what you said once?
So tell me, from the anesthesia perspective, what do you? Before I dive in on my thoughts on gabapentin, what do you hate about it? Like, what's the animosity? What's the feeling here?
Ooh.
not the drug itself. It's the utilization of the
Yes.
drug that we don't
Yes.
like. I also
throwing
want
it
to add
pain, especially visceral and somatic, like it's a mandatory part of a post-operative protocol that makes us squirrely.
Mm.
I want to add a thing I learned from the human side when I was in the pain clinic is like some humans, like to to your earlier point, Chris, about how patients feel different, some humans swear by it. It is like it changed their lives. Like their lives were materially better by going on gabapentin. They felt better. They were like it's life changing. Some people absolutely hated it. They described it as being in a fog state, and it was like they just didn't feel in control, and they felt like very foggy, and they hated it. They never wanted to touch it. They never wanted to have it prescribed to them again. They thought it was like the absolute worst. And like again, we can't ask our patients how they feel. And so like I think that's what happens to our patients when we use this drug. And it's not, again, humans, dogs, humans, cats, etc. But like I can't imagine it's that different. Like I'm sure some dogs feel that, perceive that, I don't feel comfortable.
Yeah.
Yeah.
I know, and I absolutely see that in my patient population. I mean, I have many of my patients where when we're looking at them objectively, what are the criteria? Grab me video of what they look like on or off at various doses, where it's absolutely not helpful. And others, I think the tricky thing for me with gabapentin, sort of in my world, is for some of those patients who do seem to have a beneficial response to pain control. Again, do I think it's effective across the board? No. But we do have some of those patients where it does seem to be effective for whatever it is that we're treating. But the big question that I have is when we're looking at a med that can have some degree of sedation, depending on the patient, and potential for pain control, again, potential depending on the case. We also know that at least on the human side, there's not a lot of controlled studies on the anxiolytic effects, but it is sometimes used as an adjunctive for a maintenance anxiolytic protocol in combination with an antidepressant. Then I do have some of those patients where as a mood altering substance, it can absolutely be incredibly profound in the effect. But again, patient selection and really asking the question, not just this is what I prescribe because you've got behavior issues. So here's your Prozac, here's your gabapentin, here's your trazodone. But what am I actually trying to support for you from a physiologic standpoint, actually looking at that psychopharm angle of things? What am I actually trying to do? And I agree, almost all of my patients at this point, when they're referred in, assuming anybody's been managing from a behavior standpoint, all of them have some degree of clinical history with gabapentin, most with trazodone, about half with fluoxetine. So it's pretty common. So I understand the kind of ubiquitous nature of it.
Yeah.
And I also think, I mean, chime in everybody, but I have an ethical consideration for discussion, which is, if we're giving every single, patient X drug and 3 out of 100 are reacting, like, I'm not sure that's the appropriate way to practice, right? Like giving gabapentin specifically in case there's a, benefit particularly from an analgesic point of view, which I find highly tenuous. Like, I mean, I've had cases refer to me, like huge, like dental root abscesses with like facial cellulitis, and they get transferred over on gabapentin only. And it's just wild to me how inappropriate that is. But if you give, 100 patients, gabapentin and 3 for whatever reason react, for me, that's an ethical consideration to what happened to the other, 97% of that population. Like I said, it's the new famotidine. Like we hand it out like it's a multivitamin, and we really don't spend a lot. We treat it as being so ultimately benign.
Yeah.
And I disagree with that both physiologically and probably in your case, like behaviorally, right?
Yeah, it's not benign, and I think that's one of the concerns that I appreciate you bringing that up, Tasha, because it's one of the things that at least when I'm talking with my clients and we're trying to come up with whatever protocol we think is the right thing to do for them. I try to be really mindful within the conversation to say, yes, based on X, Y, and Z pattern or concern, we are trying to do this for them as a way of bettering their condition through prescribing, obviously in combination with other interventions. But I never want to lose sight of the fact that because they did not opt in for whatever that therapy is, ultimately it's something we are doing to them. And I want to be really mindful that from a welfare standpoint, that we're never sort of overlooking that. Again, if they truly are drugs that work even in a portion of the population, the likelihood of them being benign for the rest would seem pretty low. And so just because it's tolerated doesn't mean it's innocuous. And I very
Oh, I
much
like
appreciate
that.
that
Just because
perspective.
it's tolerated doesn't make it innocuous. I'm going to
Yeah.
slap that on the back of every surgeon's jacket that I know. But yeah, no, I
Do-
think it's interesting because specifically, like utilized in a pain fashion and not having any consideration for what the other effects may be to the patient. Lack of analgesia being one, but whether or not it does cause like mood alteration or like a difference in sensory perception, you know, in humans, again, a big species extrapolation. However, you know, you look at a lot of those pain studies because we're so over focused in veterinary medicine, I think, at pain management at this point that we're actually over analgesing a lot of cases and not thinking well through the protocol. But more importantly, you know, the adverse side effects of a lot of these drugs, particularly in combination, particularly a lot of the clinical doses that I see getting used. I mean, humans will report that if they have a choice, for example, between pain and nausea or pain and dysphoria or even pain and severe pruritus, they choose pain, right? Like if you look at the obstetrical papers in women who said that, for example, like they were so profoundly nauseous after the epidural or just associated with labor in general, that actually the nausea was worse than the childbirth.
Right.
You know, and the patients that they have who, for example, they put on methadone because they're addicts, right? And so they're trying to do like a weaning protocol for an opioid addiction. They will tell you that that dysphoria is worse than withdrawal, which is a massive statement because opioid withdrawal is a horrendous physiological experience. So, yeah, I just, you know, I wonder what happens sometimes to critical thinking and clinical reasoning. And right now, like I find like the abuse of gabapentin is overall
It's
like
huge.
landing in a way that actually I think is detrimental.
It's huge. Like people dispense it like if it's an actual true, tried and true analgesic, right? Like, you have patients that just go home on that, right? And I'm like, what the heck is
And
wrong?
instead of like, for example, an NSAID, because he threw up once 25 years ago, so we're not going to give meloxicam, but I'm going to send him home after an X lab on 100 mgs of gabapentin, and I'm like, well, why don't you just dance around with a stick and sprinkle like rain over it? Like it's ridiculous. Like yeah, but I'm like, yeah, we've tossed NSAIDs out.
Right.
And there's so many preclusions or exclusions for NSAID use, and they're so much more efficacious. But God knows we'll give gabapentin.
Yeah.
Yeah.
Yeah,
Right.
it's definitely abused. That's I think that's definitely bad. When
Yeah.
something goes from being a tool in the toolbox to being blanket dispensed to everybody
Yeah.
for dubious reasons, like and people forget about this, but there is placebo effect is real, right? Even in vet med, right?
Absolutely.
And
It's
it's
real for the
used.
client. It's not real for the patient, right? Like if you have a limping dog, you put them on GABA and they limp, right? Like the patient is still painful unless obviously it's a functional limp. So the owner
However,
perceive that it's improved, but an animal can't fake a placebo effect,
they
right?
can't. However, and this is again when we're working through the client, basically on sort of who is reporting benefit or not. It's one of those things that's really important. There was a study that was in the popular press, at least I think it was the New York Times, probably 4 to 6 weeks ago, and they were reporting basically observation skills in sort of your average human, and if they were shown video examples of dogs in variety of scenarios based on the story that the individuals was sort of told about what they were seeing, the interpretation of what was observed as the same video clip across different scenarios was interpreted completely and totally different. And so it's a fascinating sort of a thing about the trick of observation. And so if I'm told that this is a pain medication and I give it, and then I see 17 tail wags in the next 2 hours, I'm more likely to see those as a positive indication of affect and comfort. And that's going to stand out because of that observation bias. And then I'm more likely to report, which perpetuates the perception that it was actually helpful both for the prescriber as well as for the administrator. And now we've got, again, that kind of dogma being perpetuated with or without actual objective data to support it.
Exactly. We give humans way too much credit, like I said, but yeah.
I think that applies also to the prescriber as well, right? Like the observation bias, it's yes, from the owner standpoint, which of course is going to alter what they report about their dog, but or cat, but you know also people that do prescribe it, if they have the mindset that that's going to definitely work, they have that observational bias that, oh, this thing is actually working. Like, and we see it with several drugs out there, right? Like there is drugs that have been advertised to have a super long duration of action for analgesia. And in reality,
Like subcutaneous ketamine?
yes, that's one of them. And there is zero evidence behind any of that, right? Like, and it doesn't even make sense whatsoever, right?
Mhm.
But people still believe some people still swear by it, right? And it's probably placebo, and it's probably some observational bias in there, but it's hard to get rid of it.
Yeah.
It's really
It's
hard.
super hard. I think that placebo, I mean, I'm all for placebo if you're, for example, like, if I'm the patient, because obviously like that, the mental processing and the emotional regulation associated with healing is an important part of like
Yes.
the mind body balance. But you can't, like, I can't give my cat with pancreatitis like an Assisi loop and explain to her that it's like analgesic and that, and like set her up for bias. So either she improves pain wise or she doesn't. And then I have to be cognizant of my own bias towards that. But like I said, the placebo effect can have improved medical outcomes in people. But I really, really struggle to believe that that is true in our pet population.
So it's interesting when we look at some of the human animal bond dynamics. I do wonder though how much there can be some of that. I don't know what the right terminology would be, but transference of placebo benefit. That if you have an owner who is, as an example, who is sort of worried about the overall health and well-being or physical comfort of their animal, but now I've got gabapentin to give you, so I feel better, so I'm breathing more easily, and therefore that cumulative stress is less impactful in a negative way. Does the placebo effect actually have some carryover if it changes the conversation or the dynamic? Which again, wouldn't be an actual direct effect on pain per se, but if we're looking at some of the other pathways that we're sort of looking at there, I do wonder.
Yeah, no, in other words, we should also sedate the owners. That's what you're saying, Chris?
We would talk through it a fair amount before I would go down that pathway necessarily, but
See, at the end of the day, you're secretly going to end up being an anesthesiologist because you realize that everything is better unconscious.
I have to laugh. I'm one of these people at conferences. Beanie knows this. So I'm at conferences and I am like the social butterfly. Like I am in the midst of it. Like give me an exhibit hall and the opportunity to like socialize and engage in conversation. And I'm the one at the front of the room answering every single question, literally until I'm the last one in the room and they're turning the lights out on me. So that is my worldview of how I approach things. So very much at opposite ends of the delivery of veterinary care perspective, perhaps.
Yeah, no, if you go to an anesthesia conference, there's always a social function, which is attended by less than I think half of the people, because people like the other anesthesiologists will be like, I'm not going. I don't want to see the other anesthesiologist. Like that's how little we like people. We don't even like each other. So, right. And like if you go to like the actual exhibit hall between lectures, like everyone just walks with like their face down because they don't want to make eye contact and have to talk to a rep. Like, yeah, like this is wild. Like if I went to a behavior conference, I'd be like, oh, overstimulated.
Oh my god. For sure. For sure.
We should do that. We should hijack on a behavior conference.
I
And
would love to see y'all sitting in the corner just like watching the craziness that unfolds. Like the last behavior conference granted this was after the bar closed, but we were doing a human pyramid on the streets of Minneapolis, and I think we had 4 layers to the pyramid. I mean, literally, this is what was happening. I have a picture of it somewhere. Yeah,
I can't
different.
imagine that happening at an anesthesia
The
conference.
last conference I went to with Bailey, he texted me telling me he was refusing to come to the social function and to meet him at the tequila bar down the street, but don't bring anybody.
And that tequila bar was the best margarita I have ever had.
That tequila bar is one of the most fun bars I have ever been to in the world. But yeah, you were just like, it only has like room for 8 people. So you're like, don't bring anyone. And I was like,
Yeah.
who was I going to bring anyway? I don't like anybody. So
It was like a car garage like length. Like it was as big as the room I'm sitting in right now.
Yeah,
Amazing.
and the drinks were just amazing, and it was just like, yeah, it was like
The
beside a
mullets.
dumpster, and like it had like a metal like drop down. I'm like, oh
Yeah.
god, it
Where
was
And the
was this?
mullets.
Sydney, Australia.
Sydney.
But Sydney,
Excellent.
Australia. But yeah, he literally texted me from outside the conference being like, yeah, I'm not coming. Meet me somewhere secret.
I had been there for a few minutes and I was like, I get it. I'm going to go now.
Yeah, I'm early in, I'm late out. I am here for it. So yeah,
You're always
different
there. Yeah.
different strokes.
So, do you guys, behaviorists sometimes they do prescribe fluoxetine, right, to a bunch of
Absolutely.
patients. Have you ever seen any like serotonin syndrome or whatnot, like from an anesthesia standpoint? It's like it's described. I can say I've anesthetized a bunch of patients on
Yeah.
fluoxetine. I can't say I've ever seen it.
So my answer to this when I'm talking with veterinarians or when I'm teaching my students, like I say, back in the day when I was going through my educational process, and anytime you talked about anything that was serotonergic in function, it was like, but be cautious because if you overdo it, serotonin syndrome. And it sort of stands out in my life now as sort of the way that I thought about things like quicksand when I was a kid watching like television cartoons. Like I thought it was going to play a much bigger role in my life than it actually does as an adult.
I thought the same thing.
I
Right?
also had an irrational quicksand phobia as a child. Like
I
I
was like,
was like,
it
like
must
on a
be
walk,
everywhere.
Everywhere.
I'm gonna step in it. My sister's gonna let me sink because she hates
Right?
me. Like, yeah.
Right? Right? And it's going to happen in like seconds. Anyways, so like to me, that's serotonin syndrome within my world and the prescribe. Like, can it happen? Absolutely. With that being said, the only times that I'm ever typically even kind of aware of it as a potential is either in cases of acute overdose. So the cat that ODs on venlafaxine, for example, because it tastes yummy to them. Well, I don't know why, but it does. So like something along those lines. Or if we have a patient who's been on, let's say, maintenance fluoxetine, and they go into a new clinic and someone's like, oh, I think they have cognitive dysfunction. Let's throw anapril or selegiline on top of that. And we're doing an SSRI MAOI combination. Okay, that's one of the times where it's more likely to be reported. But standard dosing, clinical usage, monitoring just for routine, function and tolerance. Nah, I can't think of a single case truly in 20 years where I was like, that was that. Not to say that it couldn't have happened, and I see some cowboy doses coming in for some of my patients, including, oh God, this morning, literally, I was doing a consult and like this owner doing their due diligence of doing what's been giving what's been prescribed, but they were listing it was just crazy doses of all of the medications. And I was like, wow, and your dog is bouncing around like an out of control Labrador. So clearly they're doing okay and not dying of serotonin syndrome. So mindful, not concerned, generally speaking, as long as I'm only sort of when I'm using one antidepressant at a time. That's my main concern.
Do you have any like idea or speculation? Like, is it a specific interaction with humans, or is it a dose relationship that we use in dogs? Like we in the anesthesia world, they are lectured hard about this. Like if a human is on, you know, like antipsychotic type drugs, you have to be really cautious with drugs like methadone and like many of the drugs in the opioid family because serotonin syndrome is real and happens in the OR in the pre-op period not infrequently. And I wonder why. Like it's such a fear for them where it's like we are so lackadaisical about it.
Yeah. No, 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 no. So of the drugs that we're using routinely in the veterinary space, which would be the parallels, right? In terms of where that's likely to show up.
I mean, I always think of like the fluoxetine and the trazodone as
Yeah.
being like culprits from the human side, but I don't know if there's other like they're also on like tricyclic antidepressants not uncommonly and like a litany of other drugs that we don't see as regularly, and so
Right.
maybe that's a piece of it.
Maybe. I mean, I know that there are some differences from a metabolism standpoint. I know even on the TCA side of things, with with that kind of the older generation antidepressants, there are some of the drugs like clomipramine, the generic of Clomicalm, that we use in the canine world. Where one of the big concerns there with that particular drug in humans is an arrhythmia. I forget. Don't ask me about arrhythmias. So it's one of those prolongation things that I don't remember from my boards. And anyways, it happens because of one of the secondary metabolites of clomipramine in humans. But the difference in the metabolic pathway is so different in dogs that even when it's looked for, it's not appreciated, even at high doses. So, I mean, I know that there are clinical examples like that where there are substantial differences either in metabolism or side effect profiles, including some of the things. And obviously, this is a very different example from what you were mentioning. But, if we're looking at dosages of benzodiazepines, for example, when I think about the doses of an oral benzo that I would prescribe from an anxiolytic standpoint, I know that I'm going to get a call from the pharmacist thinking I'm trying to like obtund that animal into like next Thursday based on the doses that I'm prescribing. Like there, one of my first cases, I was a baby resident. I was like probably like my third day of seeing actual cases on my own. And I was seeing a Labrador sized dog, probably 27 kigs, something like that. And we were going to be using diazepam on an oral basis to be able to support the dog at home, separation anxiety. I didn't know it, but the owner was a psychotherapist. And so I'm like, well, oral diazepam, 0.5 to 2 mg per kg up to Q4. And I'm saying, okay, we can use 15 milligrams all the way up to probably 65 or 70 milligrams of diazepam. And she looked at me, and then she looked at my mentor, and she looked back at me and like was completely dumbfounded by the fact that I would do that routinely. And, so again, it was one of my first introductions into the mindset that people are not dogs, dogs are not people, and cats are completely different in and of itself. So.
Oh yeah, I mean, I had some interactions when I was at Ohio State with they collaborate with the children hospital there, and some of the researchers were struggling to keep pigs asleep, and they were using kids' doses of like fentanyl and drugs, and I was like, yeah, that needs 50 times more. That's not.
This pig is made of pure fat, and you're those doses right up.
I was like, that's not a kid; it's a pig.
Yeah.
And they were like struggling, right? Like, they were like, why do they keep waking up? They don't go to sleep. And I was like, yeah,
because you're not actually hitting effective.
Waving the wand at them.
You're whispering anesthesia to them, but that's about it.
Yeah, get the gabapentin.
That's awesome, guys. Well, we're coming up on the hour, so I guess thank you so much for being here, guys. Thank you so much, Chris, for coming in as our first guest ever for the Random Anesthesia
Perfect
Topic
first
podcast.
guest. Like, great sense of humor. Yeah.
It is the best. That's why I was like, if it has to be one, it needs to be you. And so,
praise indeed, because as you may have discerned, we don't like anybody. So.
Well, and the fact that I survived an hour hanging out with 3 anesthesiologists, like this is an epic new for me as well. So,
We didn't even cocktail tonight because we were trying to a little bit seem professional and be on somewhat good behavior, but normally we cocktail when we do this. So,
well, if you ever invite me back, I will totally. That I'm still at the office today, so I'm still in work mode, being on the west or the best coast, depending on how you interpret that. And so I'm still at the office.
It's better than the ice storm here in Ontario. So,
also true. Yeah.
Well, thank you so much, guys. We appreciate you. See you next time.
Bye.
Bye.